Good afternoon. My name is Robert May, and I am the Executive Director at the Kensington in Redondo Beach. Welcome to Kensington Senior Living Presents UCLA Easton Center's Alzheimer's Detection, Diagnosis, and Treatment. One in three older adults will experience some form of dementia. So why are we or families not talking about this? Alzheimer's has many causes that are intertwined in a complex disease picture. It is perhaps more like three-dimensional chess. What matters is the combination of your age, your overlying genetic risk profile, and how your lifestyle choices either protect or damage your brain. We can't control our age or genetic risk profiles, but we can control our lifestyle. We can control the health and resiliency of our brains, and by doing so, can significantly delay or completely avoid the debilitating aspects of this disease. The truth is that Alzheimer's develops decades before diagnosis. It's during those decades that the brain becomes increasingly vulnerable to what we eat, how much we exercise, our ability to manage chronic stress, and the quality of our sleep, and of course, the ways in which we challenge our cognitive abilities. Here at the Kensington in Redondo Beach and in our other communities, we provide memory care in two unique settings. One is called Haven, and the other is called Connections. We understand that this disease creates significant differences in cognitive impairment, and that is why we have two different memory care neighborhoods to offer our families. It is my great pleasure to introduce the moderator for our event this afternoon. Please welcome Monica Moore, Community Health Program Manager at the Mary S. Easton Center for Alzheimer's Disease Research at UCLA.
Thank you, Robert. Good afternoon, everybody. It's a pleasure to be able to be here. The Easton Center would like to thank Kensington Senior Living for being so kind and wonderful partners to us to be able to allow for presentations like this to happen. And we are able to reach out in this virtual world of Zoom to still be able to connect and spread one of our missions about the world of educating people about Alzheimer's disease and other forms of dementia. The Easton Center is a comprehensive care center based on the Westwood campus in UCLA. We have three different arms to our center. One, we have our clinical trials program, which is a fairly robust program. We have our researchers in their labs trying to figure out Alzheimer's disease, trying to figure out what is this and why, what can we do about it? How can we change it? And we also have our neurology clinic. Today, it is with great pleasure and a great honor for me to be able to present Dr. Sarah Kremen to be our speaker for this afternoon. Dr. Sarah Kremen is the Clinical Associate Professor in the Department of Neurology at UCLA. She is the primary investigator for the UCLA California Alzheimer's Disease Center, and she's the director of the Seidel-Kagan Alzheimer's Disease Treatment Development Program. She has quite a mouthful, and it is quite a pleasure to be able to have her here today. Welcome, Dr. Kremen.
Thank you so much. It's nice to be here today.
So we want to get started. Today, our presentation is we're going to be talking about some of the latest advancements regarding Alzheimer's disease. And so Dr. Kremen, if you want to share your screen with everybody so that we can get that started and we can start this presentation.
Okay.
Wonderful. Thank you. So Dr. Kremen, first of all, before we get into the interesting discussion today, I wanted to ask you a little bit about if you could just give us a brief overview as to what is Alzheimer's disease. You know, we always say that no matter how often we give these presentations, these are always some of the questions that we have. So we want to make sure that we address that at the very beginning. So Dr. Kremen, if you would. Sure.
So first, before I jump into that topic, I just wanted to quickly put up my disclosures. I have been a site PI, principal investigator for various studies, which we are not talking about today, and that are looking at treatments for Alzheimer's disease. And I've also worked for UpToDate, which is a physician resource. Okay, so moving on to our topic at hand. So what is Alzheimer's disease? So I'm going to be presenting this idea as a background idea and as a foundation. But what we know about Alzheimer's disease goes much more beyond this slide. But over the past, say, 20 years, maybe 30 years, the hypothesis behind why we develop Alzheimer's disease goes as following. Over time, we have aging and we may develop some illnesses or other things, but there over time is a development of inflammation, and we get an aggregation of what's called amyloid plaques, which are seen in the left insert box here, if you can see my arrow. And amyloid plaques eventually build up and they cause more irritation and more inflammation. And over time, along with other processes going on in the brain, like oxidation and excitotoxicity, things that are bad for the brain, you end up causing an irritation, and we cause the misformation of tau, which is the other important protein in Alzheimer's disease. And tau accumulates inside of the neurons, and it isn't good for the neurons. So over time, the neurons will die. So you go from a healthy neuron to a dying neuron. And once the neurons start to die, they can't talk to each other. And that's when people start to show cognitive and behavioral problems. And so if you look at the panels on the right-hand side, this is a model of how tau spreads through the brain. But you'll see that it starts in one area and over time, it'll go throughout the brain. And typically the reason that we have people who experience memory problems as a very key sign of short-term memory problems is because the tau and the amyloid have gone there first. That's a very typical place for it to start. And as these proteins accumulate and spread through the brain, then we see other things, say with naming or visual spatial disorientation, and that's a sign of the disease has progressed to those areas of the brain.
Dr. Kremen, really fast, and I want to apologize to everybody who's there. If we will have time for questions and answers at the end, so if you could, feel free to put them in the question and answer section at the bottom of your Zoom page, and we'll be able to have time for Dr. Kremen to be able to answer those. So I forgot to mention that at the beginning, so my apologies. Sorry, Dr. Kremen, you can go to your next slide now.
No worries. All right, so this is a slide that tries to explain how Alzheimer's disease progresses. So you'll see on the left-hand side on the x-axis at the bottom, the time course of clinical disease stage. So there are people who are cognitively normal, and then they progress through a stage called mild cognitive impairment. That's what MCI stands for. And that's when you may have a cognitive difficulty, but you are still functioning fine. And then as the time goes on, you can develop dementia. And dementia simply is an umbrella term, which means you have a cognitive decline accompanied by a functional decline. And there's many different causes of dementia. You could have strokes that cause dementia. You could have from other types of infections that eventually cause dementia. Parkinson's disease and Alzheimer's disease is the one that we think of most commonly because it's the #1 cause of dementia. So what you can see is during the period of normal cognition, which is most of our lives, you can see that over time, at some point, silently, amyloid starts to build up. And soon after that, tau can start to build up as well. And at some point, people will start to have some memory difficulty. And that is when they start coming into the neurologist's office saying that they're having a memory problem, and we might diagnose them with mild cognitive impairment. Once they pass through this threshold, you can really see that the green line of brain atrophy, which just means brain shrinkage because neurons are starting to die, and memory loss start to happen more quickly, and eventually people start to have functional decline and they pass into dementia. What we really see here, though, is that by the time people start having a memory problem, you can see that the amyloid and the tau at this first dashed line, when people are just starting to feel something, that amyloid and tau has already been accumulating for a very, very long time. So that's the basics of the amyloid hypothesis and the tau hypothesis.
So thank you for that. I know you and I always enjoy talking about this slide in particular because we think it's such a great representation of what's happening inside the brain. So we know the world of plaque and tau, and the amyloid and the tau. We've heard those terms. Most people are familiar with those. Those were, some of the very first things that were identified back in 1906 by Dr. Alzheimer. But what are there other ways that a clinician, a neurologist is able to detect Alzheimer's disease in the brain?
So that's a really good question. At the moment, just to talk about these proteins first, is that at this point in time, I'm sure many people are familiar with brain MRIs. We can detect whether there's been any change in size of the brain or a particular area of the brain that has become smaller, say on a brain MRI. We can also see if people have strokes. You cannot diagnose Alzheimer's really from a brain scan per se, though if you see parts of the brain that are smaller, say the areas that subserve memory, that would be part of a puzzle piece to help you support the diagnosis. Other things we can do now are looking at amyloid and tau. And the first way that this was discovered was actually by doing a lumbar puncture, a spinal tap, and taking out fluid, and we can actually measure the proteins amyloid and tau. Though this might not be done in your general neurology office, it is done actually quite frequently at academic centers, even in the clinic, not just for research purposes. And we don't do it all the time, and I'm not going to get into the when we do and when we don't, but it's a very, very fairly simple test to do, though it is invasive because it is a spinal tap, but it can give us a pretty good picture of what's going on. The sensitivity is pretty high for these tests in terms of diagnosis or ruling Alzheimer's out. The other tests that some people may be familiar with are PET scans. PET scans are a little bit different from MRI. MRI shows you anatomy of the brain. PET scans show you different things. There's one thing that's called an FDG PET scan, which looks at metabolism of the brain and how the brain metabolizes glucose. And we know there are certain patterns associated with Alzheimer's disease. So sometimes people are sent for an FDG PET scan. Also, more recently, since about 2012, 2014, we now have amyloid PET scans. Now, those scans can detect amyloid in the brain, and they can also help us with the diagnosis of trying to figure out if somebody has Alzheimer's disease. What's really exciting is that in the past couple of years now, we have all these other things that are considered biomarkers, markers of disease, that we are learning about in trying to diagnose and detect Alzheimer's disease and other diseases much earlier than we can now. So some of the ones that are important, though I will not be speaking about them today, for example, are neuroinflammation. But that is a very, very important topic. Also, synaptic dysfunction, how the neurons talk to each other. We can actually measure that. But today, what we're going to talk about is the exciting things that have been the developments in blood biomarkers, actually being able to detect biomarkers of Alzheimer's disease in the blood. Because if you think about it, in the end, we want to be able to detect Alzheimer's disease more easily without something that's expensive and something that's not invasive and something that may not involve radioactivity, because all the PET scans, you have to get injected with some sort of radioactive tracer.
So I know that I believe, oh, no, go ahead. You speak on this. Go right ahead, please.
Okay, so what's really interesting about amyloid, amongst many things, is that it comes in many lengths. That's where the 40 and 42 comes from. We know that there's a big precursor protein that gets spliced in different ways and gets cut up. And the 40 and 42 relate to the fact that the little amino acids, which are essentially the little proteins that are hooking together to make these larger amyloid proteins, typically are found mostly 40 amino acids long and sometimes 42. And then you'll see that I've also put in a 39 and a 41 because they're generally between 37 and 42 amino acids long. But the most common is 40. 90% of the amyloid is 40 amino acids long. And this is more soluble liquid amyloid and tends to show the background level of amyloid. But 42 is the kind that tends to clump. And that's what the amyloid plaques seem to be made of. So what's really exciting is that there has been development now of an ability, not only in the spinal fluid, but also in the blood, to be able to detect amyloid beta 42 and 40 in the blood, which until recently was pretty hard to do, but they now have new techniques to do it. And one of the things they look at is this A beta 42 to 40 ratio. What it means is they are taking the amount of A beta 42 and measuring it over the denominator of 40. And what that shows is that as Alzheimer's disease develops, 42 goes down. what that means, you'd think it would be going up because, you're developing Alzheimer's disease, but actually it goes down. And the reason that it goes down is because if you think about amyloid floating around, it has to leave the brain and it has to go into your circulatory system, say in your arms and legs, through your blood vessels in the blood. So if you detect less beta 42, that means it's actually clumping in your brain. It can't circulate anymore because now it's clumped in your brain. So as that level goes down, it's a marker of increased risk for Alzheimer's disease. Go ahead. Did you have a question?
Yeah, I was just going to say off of that, and I know you and I spoke a little bit about this, but last year in the news during the summertime, there's a good amount of information from the Alzheimer's Association International Conference that came out talking about a blood test.
Right.
So it sounds like that's where you're going with this right now, but thinking about this world of this blood test that I know with the caregivers that I work with, they have mentioned this and saying, oh, is this available? When can we do this? And also the world of why, like why have this? But I guess you just spoke on that. It's a lot easier to get pricked and get some blood out than it is to do a PET scan. And obviously that's less costly. So if you could you speak at all about that blood test and about what the future of that might be and what that looks like for everybody who's here?
Yeah, absolutely. So I'm not going to go, I don't want to be I'm not paid by this company and I don't want to be advertising. But but it's so exciting because it is the first blood test that's available now. And this is just a harbinger of what's to come. This is going to be our future, probably, maybe not now, but in 5 years, this may be something that's really going to be much more common. So it's called the Precivity AD blood test. It was developed by Randy Bateman at University of Washington, which is one of the big centers for Alzheimer's disease research out of his lab. And essentially, he's developed a way that's very sensitive, about 90% sensitive, to detect amyloid beta 42 and 40 in the blood. And essentially what this test is for, it's very specific. It's to help doctors diagnose the probability of a patient having Alzheimer's disease, but with caveats. So you have to already have a memory problem. You have to be over age 60, and it can only be obtained through a physician. Right now, it's licensed in 46 states. The reason it's not licensed, I'm not going to go into the ones it's not, but there's 4 that there's not. You can go to their website. And the reason is because there are different licensing rules across the states. This got an expedited device approval from the FDA. It's not officially approved, meaning that it will have to go through other tests to get the official FDA approval, like most of our medications. But when it gets an advanced device, it's an exception, they are able to do this test. It is CLIA approved. What that means is that if you're ever going to give a clinical diagnosis, you have to have a certification. So they do have that. Essentially, it is not covered by Medicare or any sort of insurance right now. That's going to have to be determined because it's so new. And it has been tested against the amyloid PET scans in terms of equivalence or spinal fluid equivalence, and it's very, very good. But what we still don't know is how it equates against the gold standard, which is basically looking at people's brains under a microscope, the pathology of amyloid. So there are some things that need to be done. I mean, it also it was developed with 688 people. So it's going to have to be used more widespread, but it's exciting and it looks like it will be very helpful in the future, and to your question of why would we want to know this now, right? One of the questions is, why do we want to know this if we don't necessarily have a drug yet to really treat this disease? But it's really important because of several things. One, it could more easily identify people to participate in trials for Alzheimer's disease. So it'd be much quicker than all the stuff that we do right now in terms of study, all the tests that people have to do to even get into a clinical trial. Second, it would be very helpful in the future because one day it will be easier to make a diagnosis. And even now with family planning, I can't emphasize enough how important it is for people to be able to make plans with their family while they still have an opinion and can voice it, to be able to help a patient and their family make a decision about what to do. And this is just some interesting data showing this was a study done by how much money could be saved if we could use, if we had a blood test. And it looks at, if you look, I've circled at the bottom, but if you take all comers ages 65 to 85, overall, you'll find about 30% of them will have an amyloid PET scan that's elevated, showing that they have amyloid. But if you do amyloid scans, you'd have to do 333 of them to find 100 people who have an amyloid positive PET scan. But if you actually do a blood test, then you only have to do 125 of these scans. So it's a percentage of 62% for screening. So that's a big deal, because PET scans right now are also not covered by Medicare or any insurance either. They're out of pocket.
And that especially sounds great in terms of the world of clinical trials, like you mentioned, because having to go through such invasive procedures just to see if someone is eligible or not is really difficult. This would really be able to streamline that a lot.
Right. And we really want to speed up, getting to some drugs. So this would really speed this up a lot.
Absolutely. So I know, as has been the world of Alzheimer's research, we talk a lot about amyloid and we talk a lot about amyloid. Are there other biomarkers that currently are being that are being used to that might be able to help with detection of Alzheimer's disease, or some that might be like on the forefront of research right now?
Sure. Yes. One of the biggest ones is called neurofilament light, or NFL for short. And it is a biomarker of axonal and neuronal degeneration, basically the breakdown when neurons are dying. So the reason it's called neurofilament light is because if you look at this cutaway on the left-hand side, you see this yellow axon, and it's covered with a myelin sheath, which is the light blue. Essentially, you can think of the axon, this part here, as it's like a wire. And so you know how a wire, you have the metal wire, and then it's surrounded by plastic or by rubber. That's the outside, and that helps the signal continue down an electric wire. It's kind of the same thing with the neurons, that the signal is being sent down by that gold wire. Okay, that's the axon. And it turns out that it has microfilaments, and it turns out that what they can measure is there are heavy chains, there are medium size, there's light, and so this is the neurofilament light. It's that filament that's light. That's less kilodaltons, which is their measurement for it. So what's really exciting is that not only in spinal fluid, but now also in a blood test, they are able to actually look at neurofilament light levels in patients and actually be able to distinguish between people who have normal cognition and those who have mild cognitive impairment, or those who have actual dementia. It turns out that neurofilament light is not specific to Alzheimer's disease per se. It's actually really helpful in seeing neurodegeneration of neurons for all kinds of diseases. So in Huntington's disease, in multiple sclerosis, in Parkinson's, we see it elevated in many neurodegenerative conditions. However, what's really interesting is that it seems to be a very early marker, and it tracks very well with tau, and even the parts of tau that are very particular to Alzheimer's disease, the phosphorylated tau, which I'll be talking about a little bit later. This is a really interesting study that I'm not going to get into the weeds on it, but this study was performed in the DIAN study. That's the Dominantly Inherited Alzheimer's Network. This is a study that is following people who have a very particular type of early onset Alzheimer's disease. Most people do not have this type of dementia. It's in less than 1% of people who have dementia. They actually have an identifiable dominant gene that causes them and their families in each generation to develop Alzheimer's disease, usually in their 20s, 30s, or 40s. It's very, very early. So this population, because these families are so affected, are just amazing people who have volunteered to be in the DIAN study. And they are followed, people who are affected and their family members who are not yet affected, over years. And they have donated their blood and their spinal fluid, and they do brain scans. And what's so interesting from this group is when they looked at neurofilament light. On the left panel, it was in spinal fluid. That's cerebral spinal fluid is CSF. And on the right-hand side, in their blood. What they were able to detect was at baseline that they could detect changes in the people who are actually the carriers that have that gene, the dominant gene, an average of like 6.8 years before they were about to have cognitive difficulties. And when they took multiple measurements over time, what they could see was they could actually start to see a change in the rate of the increase in these mutation carriers 16 years before they started having memory problems. So they could tell 16 years beforehand that these people were going to have problems. And what's really interesting is that this same type of finding has also now been seen in at least one paper that's been done on typical onset Alzheimer's disease that's not linked to this particular gene. So the neurofilament light is going to be very, very important. It can really track with amyloid deposition in the brain in certain areas. It tracks with tau, and it tracks with certain areas of the brain that we see that get smaller at the beginning of Alzheimer's disease. So it's going to be a good way to track disease.
Yeah, this is, I know this is something that's really interesting. If you think about it, like we think about the hallmarks of the disease. Again, we mentioned amyloid, but neurofilament light is something that I'm sure most people here haven't heard of. And to even see that this is an option and that this is an area of research, I think that's always so wonderful and great to be able to bring to everybody. As we talk about, again, the hallmarks, it's amyloid, and then there's also the tau tangles. Do you have some slides for us that we can speak, that you can talk about that a little bit as well?
Sure. So again, neurofilament light, not ready for prime time in clinic, but it's coming. And now tau. So tau is the other thing, of course, that has been so important, and you'll read, it's in all the research papers from the get-go about Alzheimer's disease. So we'll talk a little bit about what tau is. So as on the left-hand side, you see again a cartoon of an axon, a neuron, and with its axon. And inside that axon you'll see these microtubules. These microtubules are put together in various formations, and it's really the tau, these little orange things here, that stabilize the microtubules. The microtubules are really important because they help the neuron. They're sort of like a railroad for all the packages that have to go back and forth and travel inside of an axon and keep it healthy. And the tau is the way I think of it, whether this is that it's a ligament. It's sort of keeping like if you think of your fingers or your knees, they're kept together with ligaments to help keep them strong. And the tau kind of is like a ligament for the microtubule parts. So tau has various formations. When it's just floating around free, it tends to be in a folded up paper clip type of formation, which you can see up above in the first panel on the top. And you can see that's wrapped around, and it has an N end and a C end, and we're not going to get into what that means, but those are, but it usually if it's floating around, that's the kind of formation. And the reason it's like that is because it's protecting it from reacting with other things. But when it's unfolded, as you can see in the top, that's when it's usually bound to something. So when it is bound to the microtubule, as you'll see in the bottom panel, it unfolds and it is attached by this binding portion here. So what happens in Alzheimer's disease is that the tau at certain places starts to become bonded to these phosphorylated, becomes phosphorylated, these phosphates here in the yellow with the P. And when that happens, it changes the conformation of the tau, and it causes it to basically detach from the microtubules. And then, as you can see here, we've got a bunch of big words: phosphorylation, ubiquitination, oxidation, glycation. And what that just means is that there are various chemical processes that happen, and eventually what you get is these tau sticking to itself. And that causes the tau tangles. And when you have a tau tangle, that's what causes the neurons then to not be able to function. Okay. So this past summer, at this big conference, the annual conference for the Alzheimer's Association, their international conference, one of the biggest hits was that they're now coming out with tau tests as well, in that not only in the blood, in the spinal fluid, but also in the blood. And what really made this splash was p-tau 217. So it's just, all that means is that it's a phosphorylated tau at the 217 place along the amino acids. So in general, when we diagnose, say, by spinal fluid, the amyloid and tau, there are two types of tau that they can measure, that we get a measurement. We get a total tau measurement, and we get a phosphorylated tau. And the phosphorylated tau is really the one that when it's elevated says, this is elevated tau due to Alzheimer's disease. Because there are other diseases where you might have elevated tau. For example, frontotemporal dementia, can have elevated tau. So this helps us differentiate. And what's really exciting now is that they're able again to find phospho-tau in the blood, not just 217, but also phosphorylated tau 181. And it looks like between the two of them that they're both very sensitive, but 217 seems to be even higher, more highly correlated with Alzheimer's disease, and goes up even earlier than they can detect it in phosphorylated 181. So the accuracy also seems pretty good in terms of using both of them to distinguish between Alzheimer's disease and other tau-related diseases. So this is not yet at all prime time, but the researchers in this field can see that there's going to be, it's not going to happen next year, but they are definitely, this is already happening in research, and it's going to be incorporated. I'm sure it may be already in some of the screening that's going on to determine who can be eligible, say, to get into clinical trials. It's done as part of clinical trial workup. So this is going to be happening, not next year, but it will be happening probably in the next 5 years, which is pretty exciting.
Yeah, absolutely. I think, you think about just this world of, years ago, you think of like a basic diagnosis would just be, do you meet, how old are you? You're having some memory problems. Okay, it's probably Alzheimer's disease. We'll see you in a year, where that was a basic diagnosis. Very crude version, of course, but just there weren't these a test to be able to really look inside a person, look at their blood, look at the brain scans and all that stuff. I think we've had like an incredible amount of information here, and this is so good and so exciting to be able to share this information. I know we are sort of coming up on time. It always goes so incredibly fast. I never know, it always blows right by, but I want to make sure that we get a chance to answer some questions. I know that I did see one question in the Q&A. And again, if you have questions, please put them in the Q&A section, not the chat, but in the Q&A section. And I'll be able to monitor that to be able to answer, ask these questions. Then I received a few others that if we have time, I'd like to be able to get to as well. So we have a question regarding the blood test. Would this blood test determine a distinction between Alzheimer's dementia versus Parkinson's dementia?
So if you're talking about the amyloid test, yes. Basically, there are different proteins that are accumulating for these different diseases. So Alzheimer's disease really is this accumulation of amyloid and tau. And by definition, from a pathologic point of view, you don't have Alzheimer's disease unless you have both amyloid and tau. So like, say, even when we do PET scans that are amyloid scans, all that really tells you is that you have elevated amyloid. It tells you nothing about the tau. So you can't even really make a diagnosis of Alzheimer's disease per se, even off of a PET scan that shows only amyloid. You'd really need an amyloid scan and a tau scan. So in terms of Parkinson's disease, the protein that accumulates in that process is called alpha-synuclein. So it looks totally different from amyloid and tau. And they are working on this. Alpha-synuclein is a big one because not only is it affecting people with Parkinson's disease, but that's also the underlying accumulating protein for dementia with Lewy bodies, sometimes for cortical basal syndrome. So there's other, other types of Parkinsonian syndromes that that alpha-synuclein is the underlying factor. And it just turns out that alpha-synuclein is a little bit harder to isolate. So they have been doing the same sort of studies looking at alpha-synuclein in the spinal fluid. It's less easy to do right now, but they're working on it. So, of course, the goal is that one day, we could test for all of these things in the blood, but not now. So right now, basically, if you got an amyloid test, it would basically really be more specific for whether you have amyloid and in combination with tau, whether, it looks like Alzheimer's disease or not.
Great, thank you. And then we just received another question asking, are there any trials going on for early to moderate dementia?
Yes, lots.
I almost wanted to
quick answer. So this is what I would say. There's many studies for people, specifically for people who have mild cognitive impairment due to Alzheimer's disease, and also people who have mild dementia due to Alzheimer's disease. And there are some also for moderate as well. So what I would, I don't want to get in, it's such a huge field and such a big topic. We have to do another talk on that instead. But this is what I would counsel is you go to clinicaltrials.gov. It's clinicaltrials, all one word, .gov. And if you type in Alzheimer's disease and the state that you live in, you can find sites that have active studies going on. And that's a reliable website. The one thing I would counsel you to do is don't go to any, if you're ever asked to pay to get into a study, walk away. That's a red flag. You should never, ever be asked to pay to get into a study. All these studies don't have a transaction like that. So, but the clinicaltrials.gov is a reliable website to find studies.
Great. And another question here, in regards to medication for people who are already diagnosed, have there been any updates? I think this is a very topical question,
Yeah.
given the past few months.
Oh
So,
my gosh, yeah.
yeah.
So a brief, highlight. We did not, we just, I knew we would come around to this even if we didn't make slides for it. So there's been a lot of talk about aducanumab, which is Biogen's drug, which is an antibody directed against the kind of amyloid that clumps. So this is a big deal, this study. It made it to phase 3, which means that they had people who had the disease, and they had a large number of people. They actually had 2 separate studies, Engage and Emerge, that were going at the same time. And they had over 1,000 participants in both. And their initial indications were that there was some benefit in terms of reducing the rate of decline in function and cognition. But then they didn't meet their endpoint, their cutoff. They had an interim analysis. And so it was stopped in March of 2019. Then, then they did a post hoc analysis, and they decided in the summer of 2019, I just have to get all this stuff right, that they were going to put it back on. And now it's gone before the FDA. So this past summer, they actually applied for an application for expedited review, and the FDA looked at it. And then in November, they had the external panel weighed in, and there's expected to be a decision by March 7th. The long and short of it is that it's sitting with the FDA. The external panel had major concerns about it, and those concerns arise around potential complications from giving the medication. Any medication, not just this one by Biogen, but all the ones by every single big company that's making them, anything that has to do with an antibody directed against amyloid, these medications all have the same risk, which is basically a risk of causing brain bleeding or brain swelling. And so in the Biogen study, especially if you had a specific risk factor that they would determine, a genetic risk factor, that could even increase your risk by quite a bit. So maybe, 2/3 of people or 75% of people had some amount of brain swelling and bleeding. That said, 2/3 were asymptomatic and most of them were able to complete the study. But it has worried people. The other thing is that people felt that it didn't quite really meet the goals because they stopped short. And one of the studies, the Engage study, didn't actually meet the endpoints that they wanted. It didn't really prove necessarily that they had shown a decline in the rate of decline. So they didn't show improvement for these people. So the jury is out. We don't know if the FDA is going to approve it or not. Honestly, on the one hand, if it gets approved, it would be a big deal. It'd be the first drug since 2005 to be approved. And not only that, it would be a disease modifying drug, not just a supportive drug, which is what we have now, but we'll have to see. On the heels of that, we just found out, in the past week or two that Lilly's phase 2 drug, donanemab, looks like it is showing some slowdown in the rate of progression of functional decline and cognitive decline. So that's exciting. And then there's another drug, gantenerumab, being used in the people who are in the Diane study. And that also looked like it showed some. So we're getting there. There are going to be drugs on the horizon, and those are just the amyloid, drugs. There's other ones in the pipeline. So though we've been waiting a very long time, I continue to be hopeful that there are going to be drugs on the horizon.
Wonderful. Thank you. And, we have a few other questions here, but I feel that we're definitely running out of time. I don't think it's not exactly fair to you to ask for this one question in our final 2 or 3 minutes, but I'm going to ask of you anyways, just because I know that you could do it. Are there any, and again, it's something that I know you and I talked about when preparing for this presentation. What do you suggest in terms of for prevention, risk reduction? What can people do now in terms of diet or exercise? We know having a McDonald's diet's not a smart thing, but
Right.
what can we do now to be able to keep our brains healthier longer?
Right. So I guess I could go slip to our slide. We were anticipating this question. So, well, we don't have time to talk about all these things, but this is really the story of where Alzheimer's disease is going, and is really going to be could be a topic for a whole nother session. But the bottom line is that Alzheimer's disease is not all about amyloid and tau. It's really not. And that's what we're learning from a lot of population health studies. So, your biggest risk factor is aging. None of us can get out of that. That's all of us have that. We're all getting older. So that is the #1 risk factor for developing Alzheimer's disease. And of course, there's genetics that plays some amount of role. But really what you need to do is look at all these other things that I have, especially in purple. So exercise, we know hands down is important. As long as you are exercising about 30 minutes a day, even if it's walking, that's good enough. It's really, really important for reducing bad inflammatory factors and improving good and anti-inflammatory factors. It also is important for helping your brain. It reduces the rate of neurodegeneration in your brain. So exercise, I can't urge enough how important it is. Obviously, having a healthy diet, a Mediterranean style diet is good, and having a variety of things to eat, obviously less sugar, less red meat, but you don't have to stick to like these very particular diets. I don't know how much data there really is for that. Obviously, reducing your smoking and taking care of vascular health, like keeping diabetes and hypertension in check. And on the other side, there's all this other stuff like environment. Pollution is now turning out to be something that's very important that we may or may not be able to control. But social interactions for sure. We know that people who have more social connections end up doing better later in life. Mental health, taking care of anxiety and depression, those things are very important, not only because sometimes that affects our social interactions and our ability to function, but also because probably at some molecular level, those have increased inflammatory processes going on. And I can't, also sleep is also so important. So, sleep is the one time when your body is not making amyloid. So you need to get on average 7 hours of sleep, more or less. And we don't have time to talk about this beautiful slide, but this basically just shows that over the course of our lifetime, there are some things that we can't modify. About 60% of our risk is unknown or we can't modify, but 40% of our risk of developing dementia is modifiable. And it really, some of it really occurs, over the course of our life, and different things are important at different times of our life. So when we are younger, education's important. So preschool, universal preschool is good. It really shows, it's amazing, but things that happen very early in our lives have a major impact for a reduction of dementia risk later in life. In midlife, it's more having to do with traumatic brain injury and our risks, or alcohol use or obesity, exercise, and later in life, depression, being able to hear, diabetes. So there's many different ways that, and everything adds up.
And thank you. I know this is something that you and I, we can give full hour and a half presentations just on something like this. I appreciate the person who asked that question. It was a great way to wrap up our presentation this afternoon. So thank you everybody again for joining us. I'd like to turn it back over to Robert. But before that, thank you so much, Dr. Kremen. It is a great pleasure and honor to be able to work with you and for you to be able to offer presentations like this. I know you've put up the Easton Center contact information. The website is there. We have lots of information about our current clinical trials, as well as the phone number for our clinical trials department, and also the main number as well. So if you have any additional questions, please feel free to reach out to us that way as well. We'd be happy to be able to help in any way that we can. So Dr. Kremen, thank you so very much. As always, it is a pleasure. And Robert, thank you to the Kensington for being the spearheader behind this event. Really appreciate it. It's a pleasure working with you.
Well, you are very welcome. I would like to thank, of course, Dr. Sarah Kremen and Monica for this exciting and informative session on the latest advancements of Alzheimer's detection and diagnosis. This groundbreaking research on neurofilament light, for example, offers an exciting future for us to understand this complex disease. And once again, the Kensington is honored to host this event, and thanks for our presenters for their commitment to outstanding research and impassioned sharing of these amazing discoveries with us this afternoon. So thank you.